Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have a guest coming to me all the way from India. His name is Dr. Santanu Datta. He's the CSO of a company called Bugworks Research, Inc. We're going to be talking about their work there. Sounds like about microbes. So, Dr. Datta, thank you for coming. How are you doing?
I'm doing great.
Oh, good. I like the name of your company. What's the premise of Bugworks?
Our company is focused on producing the next generation antibacterials, broad spectrum antibacterials. So basically bugs, as we call. Now, when we use the word bugs, it could be meaning microbes from the smallest virus, like the COVID-19, which is a virus, or it could be a bacteria, or it could be a fungus. But our focus is on bacteria. That's why it's called Bugworks.
Okay.
There's nothing more to it. It's just a catchy name, I guess.
Yeah. So, what bacteria in what context that you're making? Like where do we run into them that you want to get rid of them?
Yeah. Okay. Let me go to the background. One of the first antibacterial that came into existence was penicillin, and we all know how penicillin played a very, very important role in human existence in the last 70 to 80 years. For example, if you go back 100 years, people would have died occasionally from a simple cut, wound, some infection. But after the discovery of penicillin, it's very interesting. One simple discovery changed the average age of human from say early 40s, mid 40s to 80s in the last 70 years. Of course, there is an economic issue to it, but people have analyzed that these days people live much longer because of the antibiotics which are there. And the golden era of antibiotics, as it is called, is from the 50s to 70s, where a plethora of antibiotics were discovered, and the humans are now much more safer. However, in the last 50 years, there has been no new antibiotics, and this has caused what is known as AMR, antimicrobial resistance. So people admitted in the hospital for a surgery, they get an infection, which is called hospital-acquired infection, and they may die due to infection, but they had gone to the hospital for something else. So 30% of the deaths in hospitals today, prior to COVID-1, was due to hospital-acquired infection coupled with AMR, antimicrobial resistance, so that the antibiotics are not working in many of the cases. And that is where we come in. We have a product which is in the very late stage of preclinical development. It will go to the phase 1 clinical trial probably in the next 4 to 5 months time. Of course, the entire time scale in the world has now altered because of COVID, but still we hope, because all our preclinical work, the toxicity work has been done.
So why have there been no new antibiotics in the past 50 years? What makes it so difficult to make one?
It's a very interesting question. There are two issues which make it difficult. Number one, unlike any other drugs, say, for example, take a diabetes or a hypertension drug, you take it for life. So there is a business end to it. There is the pharmaceutical companies which are selling the drug make a lot of money, and not that there is anything wrong in that, because making a drug is a very, very expensive process. It is filled with failures. In case of antibiotics, it's kind of a binary. You take it for 1 week, you're cured, and if you're not cured, unfortunately, you're dead. So the market of antibiotics, though it's such a huge importance in human existence, from a market dynamics, as there's an oft-repeated phrase these days, the market for antibiotics is broken. So most of the big pharmas of the world have moved away from antibiotics. That is number one. Number two, from a scientific perspective, the antibiotic discovery is it's very interesting that in the old traditional way, when people tried all the antibiotics, the molecules were tested without their mechanism of action and tested, and many antibiotics which are there today may be having side effects. But today, the entire discovery is such that we want to make it safe. The safety standards have gone up so much that it is a very, very difficult. Scientifically, it is pretty difficult. So there are two vectors. One is a scientific problem, and one is a market dynamics, which makes it not very profitable for big pharma to put its might into this activity.
Well, most antibiotics on the market, would they pass now if they had to go through the whole process of of FDA and all that, or would they not make it, you think?
No, some of them would. Some of them would. For example, the first antibiotic, penicillin, is absolutely a brilliant, and its next-gen penicillins are absolutely brilliant. They have very little side effect. But for example, there are molecules like colistin, which has a lot of nephrotoxicity and other issues. There are nitrofurantoins, which have a lot of toxicity issues. But when you don't have anything, people want to throw, their kitchen sink at it. When a person is dying, you don't care whether he has a diarrhea or a headache or anything like that. You don't care. So many of the antibiotics which are there today, or maybe many of the drugs today, for example, if you take one of the most common drug that everybody uses is aspirin. If aspirin were to be discovered today, it wouldn't have made it because of the side effects that it has. It causes diarrhea, sometimes it causes intestinal bleeding. So it wouldn't have made it for the side effects. So today's drugs are significantly safer, and the old drugs which is toxic baggage, many of them would make it, including some of the antibiotics.
Well, it doesn't seem like new drugs are safer. When I see them on TV, they have tons of side effects. It seems like they're far worse. But maybe in antibiotics they are.
It depends on the area. And today what has happened, people are much more aware. So, 30, 40 years back, people would have taken a medicine and, okay, with the medicine came a headache or a cramp or something like that. People would have, taken it with a smile or anything. I don't know what. Today, people are much more aware. So because people are much more aware, so the bar of safety has really gone up. So it's a two-way street that people know more, or we know many of the side effects which were earlier not even known. So yes, you're right. People are aware that of the side effects, and so the bar and the FDA has to react to it. So the bar has become really, really tough.
So you're working on a new antibiotic. What's the what can you say about it? Like, what's the mechanism of action, and why is this promising?
Yeah. So let us start from the antibiotic resistance. I try to explain why there is a resistance. Now, an antibiotic's mechanism of action is such that it hits an essential part of the bacteria. So let me give you a gory example. Say you have a gun and you have one bullet in the gun. You want to kill a person. Where would you shoot? You would shoot either in the head or in the heart. So in a human body, probably there are many, many essential parts, but head and the heart are super essential. So in the same way, in the bacteria, there are nodes or enzymes or what have you, which are extremely essential. Now, if they're essential, you have to hit them and that essential part and hit them hard. You don't want to hit a bacteria on its leg or its arm. Maybe it will get injured, but it will, get back again. So you have to hit on the head. Now, there are very few such essential parts in the bacteria. So you have to be clever where you are hitting. Now, the bacteria has a very unique, because it has been there much before human beings, it has a evolutionary advantage that it is continuously changing. Just like the coronavirus, we know that there are maybe 30 to 50 variants of coronavirus now in the world. So each bacteria, as it is evolving, what happens is that you want to hit very specifically on a part of the bacteria. What is the most important part of the bacteria? Say the replication machinery. That means the machinery which is utilized to make one bacteria to 2, 2 to 4, 4 to 8, 8 to 16. That is the replication machinery, which is very important. Without that machinery, the bacteria won't survive. Now, the bacteria, where you are hitting the machinery, say, one of the enzymes is called gyrase. Now, one of the common antibiotics, which was discovered in the 70s and still being used in the West and also in India, but there are a lot of resistance, is known as ciprofloxacin. It hits gyrase. Now, what has happened, the bacteria mutates in such a way that where it was hitting, that part has altered in such a way that the molecule cannot go and bind there. So, for example, you want to hit somebody in the heart, but that guy is wearing a Kevlar bulletproof jacket. So what do? You can't. So the bacteria alters its structure in such a way that you can't. So that is mutation. What we have done, what is so unique in our molecule, we are not hitting only one. We are hitting simultaneously two essential parts of the bacteria. So, for example, with one bullet, I'm hitting the head and the heart. So even if the guy is wearing a Kevlar jacket, maybe the bullet won't pierce the heart, but it will hit the head. So unless the guy is also wearing a very bulletproof helmet and a Kevlar jacket, that means double mutation is preventing it, which is kind of possible, but the probability is less. So it will become more effective, and we hope that it will have a longer lifespan in the human experience than the previous antibiotics. Most of the antibiotics generally hit one target.
Well, do the bacteria tend to adapt in predictable ways, or do they?
Yeah.
Do they mutate?
Absolutely. Absolutely. The bacteria, the AMR, what we call antimicrobial resistance, what is the base of AMR? It is the continuous mutation. The bacteria, we have to understand, unlike the human, the bacteria has evolved in feast and famine. What do I mean by that? The feast could be for a very small time, say it's in the human body where it is, having a lot of good food in the human body. But there are other times bacteria may be out in the open where it is dried up. And so it is a very, very robust system. A bacteria is significantly more robust. It can stay without food maybe for months, which is known as biofilm. So human beings cannot. Human beings need a 4 square meal a day, or even probably you can survive with 1 meal a day, but you can't go on indefinite fasting. Bacteria can fast for 30, 40, 50, 60, even 100 days, and can hunker down when the going gets tough. So that is that. So the bacteria are continuously adapting according to their environment, and using the Darwinian maxim, the survival of the fittest. They are continuously changing and trying to outsmart the human being and the drugs. So that's why there will always be antibiotic resistance, but we have to always up the ante and hit the bacteria before it mutates, or hit at two places, like the way we are doing with our Gyrox series of molecules, where we hit at two targets simultaneously with equal potency.
Well, when a bacteria mutates, I would think that there are trade-offs. You can't have everything. So if you know how a bacteria mutates and it's predictable, why can't you cause it to mutate and then also take advantage of the trade-off?
Yes, that's a very, very good point. Now, what people have seen, it's a very interesting thing. For example, exactly as you said, a trade-off. You can't have the cake and eat it too. If you use that analogy, as the bacteria is mutating, maybe it has some thing which is trading, maybe the efficiency or something like that. So if antibiotic is withdrawn from the market so the doctors withdraw a particular antibiotic for 15 years, it is seen that the bacteria becomes sensitive again. So this has been done in Scandinavia. They withdrew some of the old antibiotics, and within 10 to 15 years, it became sensitive again. So so as long as you put the pressure, it will mutate. If you withdraw the pressure, maybe it will go back to its original, or maybe something even more better. But that is always not the case. And bacterial mutation is kind of random, but random selection is always there. It is continuously mutating millions of bacteria. For example, if you have an infection, you may have 1 billion at least bacteria in your body. And even if 1 in 1 billion mutates, that if it has the advantage, it will take over. A bacteria doubles in only 20 minutes. So if it doubles in 20 minutes, you can calculate that in overnight, a bacteria from one bacteria can go into maybe 20 generations, which is 10 to the power 6, and 30 generation is about 1 billion bacteria. 30 generations would take maximum of 15 hours. So in an overnight, one bacteria which has mutated to become resistant can become 1 billion bacteria in 15 hours, 15 to 17 hours. So that is because the generation time of bacteria is only 20 minutes. Human beings have a generation time of 25 years. So for example, so the bacteria mutate very, very fast because, as I said, it replicates very fast.
Well, again, have you seen that the adaptations from bacteria? I mean, we still have, if a certain bacteria mutates, we still have ones that haven't mutated, and then we have ones that have mutated, right? Otherwise, every single bacteria would be resistant to antibiotics. So when you look at, the unmutated versus the mutated, are they mutating in predictable ways, or does it appear to be random? And they're becoming resistant in non-predictable ways.
No. So, for example, that, as I said, devil is in the details. Now, what you call at the very base, the bacterial mutation is random, but there is a selection. So, for example, let us look how a bacteria can become resistant. So there are 3 to 4 ways a bacteria can become resistant. The bacteria can become resistant by making its outer membrane, that means it's the outer surface of the bacteria such that the antibiotic cannot even enter. So that is a permeability mutant. So it won't enter. You have closed the doors and the windows in such a way that nobody can enter. So the bacteria has hunkered down. So that is one kind of mutation. The second kind of mutation is efflux. The bacteria has, as I said, that they live in feast and famine. So inside our body, there are a lot of toxic material. So the bacteria has an efflux system. So the moment the antibiotics or the bad molecule goes inside, the bacteria throws it out. So that is an efflux. This is the second type of mutation. The third type of mutation, as I said, the target mutation. Say you are hitting the replication machinery, one of the enzymes of the replication machinery at a particular point. That point has mutated in such a way that the activity is still there, but your molecule is not binding or inhibiting that target. This is the third. The fourth is the bacteria may make some molecules, some enzymes, which may degrade your antibiotics. Say, for example, penicillin is how it became resistant. It became resistant because there are some enzymes which are called beta-lactamases, which degrade the penicillin. So it enters. It is not effluxed, but the moment it enters, there are enzymes which break down the antibiotics in such a way that it becomes ineffective. So the mutation is happening in all these fronts, and suddenly the one is randomly happening. Suddenly the one which is effective is not dying, and the others which are unmuted have died. So that mutation takes that bacteria with the mutation goes forward and takes over within 1 week. Technically, in the test tube, in 15 to 17 hours in a human body. So that's why resistant. If you have resistance and you're taking an antibiotic which is not working, then what happens? Then people try another antibiotic. Let's see whether it's also resistant or not. That is how. Or if you have good diagnostic system, which we have, but it takes about 24 to 48 hours to check it out. We see which antibiotic to which the bacteria is sensitive and give that.
Which of these adaptations is the most difficult to fight? Is it the efflux pump? Is it the degradation enzymes? Which one's the toughest?
That depends on the class of antibiotics. For penicillin, degradation is the most important. For ciprofloxacin kind of antibiotics, the target mutation is the most important. For others, there are the efflux pump, and for others, there are entry. So it depends on the class of molecule which you have made. So the antibiotics have various different class on their chemical property. So depending on the chemical property, each antibiotic has a more vulnerable pathway for resistance than the other. So there is no I shared with you 4 different types of resistant mechanism, and it depends on the class of antibiotic. So there is no one rule fits all.
But for a given bacteria, let's say Staph aureus, does it preferentially form pumps over, degradation enzymes? Like, do the bacteria tend to have, they tend to do one thing over another?
Yeah. Staph aureus, for example, is gram-positive. Its pumps are not very efficient. So, for example, one of the antibiotics which is used in Staph aureus, say, for example, is vancomycin. It becomes resistant that the enzyme which inhibits now changes its mechanism in such a way that vancomycin is no longer effective. So again, if you take ciprofloxacin, again Staph aureus, you will see that the ciprofloxacin is mutated in the gyrase sequence where the ciprofloxacin binds. So again, I said that it is not dependent on the bacteria, but it's dependent on the class of antibiotics against that bacteria.
Yeah, I just didn't know for given bacteria, like which of some of the bacteria that are the worst or the toughest, most antibiotic resistant ones out there that cause the most harm.
The toughest today are probably Pseudomonas aeruginosa and Klebsiella pneumoniae. and also in the West, Acinetobacter baumannii. Staph aureus MRSA was a very big killer, and probably still is, but there have been some improvement over in that area. So gram positives are probably slightly less dangerous than the gram negatives. As I said, Pseudomonas, Klebsiella, and Acinetobacter, including Staph, would be the 4 biggest bacterial killers today.
So your new antibiotic, which bacteria are you targeting, or is it?
Oh, the very interesting question. Yeah, what we call is a broad spectrum. There is an acronym which is called ESCAPE, ESKAPE. This is E for E. coli, K for Klebsiella, A for Acinetobacter, ESKAP for Pseudomonas, E for Enterobacteriaceae. And there is one more, S is for Staph. So this escape pathogens are the major bacteria which harm the humankind. And our antibiotic is Gyrox, which is a broad spectrum because it is hitting the replication machinery, which is common to all the bacteria that are there. It is a common enzyme, common pathways, because all bacteria has to replicate, and for replication there is a specific enzyme, gyrase, which does the uncoiling of the double helix, and topoisomerase, which also does that in a slightly different way. So it hits both the replication enzyme simultaneously. So our is a broad spectrum. Actually, it is a super broad spectrum antibiotic. So the advantage is that in an acute infection, hopefully when we pass our clinical trial and it becomes really a drug, it can be given without even, if one has to just figure out there is a bacterial infection. So without the diagnostic which bacteria it is, you can give it because it is a broad spectrum antibiotic. And in an acute infections, often you don't have time to understand which bacteria because it takes time to do a diagnostic, and you have to, the doctors have to make a very quick decision.
So broad spectrum still has a place because of the lack of time in acute infections.
Yes. Not only that, many infections are multi-species. That means it's not only one. See, when your immune system is, when does bacterial infection happen? If there is an external cut or wound, well, that our immune system would be taken care of that. But if you are immune compromised, then what happens? There are many bacteria which are waiting in the wings to attack you. And many infections are not a single bacteria, but it may be a multibacterial infection. So the philosophy is, yes, if you can make a molecule which is very specific to a single bacteria, and if you know that that is the infection, then it's fine. But in many cases where you don't know, you because of the diagnostic, you need to give a broad spectrum.
What about the delivery of the antibiotic? It's just through pill. I mean, why not try to use a phage vector to deliver it?
This is a small molecule. That means a small chemical compound of molecular weight less than 500. So there are two general modes of delivery. One is, as you said, a pill, which is the easiest oral pill. But the first thing what we are doing is an IV injection, because this is targeted for hospital-based infection, which is a serious acute infection. Probably we will first, the trial will go for hospital-acquired pneumonia, where so it will be given IV in the hospital. So it will be a injection, but we also have an oral step down of the same molecule, which is coming behind our IV platform. The first platform molecule that we are going ahead, which has been funded by Carbex. I guess I should thank them. We should thank them that Carbex is probably the biggest funder today in antibacterial space. It funds. It's a fund by the U.S. government. I think the Gates Foundation, the Wellcome Trust, all put together has put a significant amount of money, and they have identified a top small SMEs around the world, and they're funding them. And so far, we have been funded by Carbex, and the first molecule that will go into clinical trial is an IV formulation, intravenous formulation.
So, are you have you started clinical trials? Are you in phase 1 yet? Or how long will this take?
So our preclinical, all the experimental data is all over, and probably in the mid-May, May is this, so maybe within a month or month and a half, we are going to have a meeting with the FDA, and if the meeting goes well, then we would start our phase 1 clinical trial, in all probability in Australia, because that is somehow the best place to go for phase 1 trial. They have got a very good infrastructure with the high quality of science, and so everybody has said Australia, and they are very fast. The speed is the essence. So if the FDA meeting goes on well, so by Q4 of 2020, we would start the phase 1 clinical trial in Australia. We are now in the process of compiling the entire document of the preclinical safety, manufacturing, all that we have done over the last 4 years. It's a huge documentation, and that document will go to the FDA, and they will look at very hard on this and look for the safety and the efficacy, primarily the safety, and then we will go into phase 1 once FDA is okay with it. Looking at the data from our side and from the Carbex's expert, it looks okay, but as I said, unless the FDA stamps that it is okay to move forward, we will not move forward. So that is the stage, that's the last gate that we are waiting, which probably will happen in the next 40-45 days.
Do you think if this is successful, it will be used in clinics, in hospitals?
After phase 1, which may take about 6 months, then we go to the phase 2, where we do a trial. Probably we will do a multi-centric trial. That means in 2-3 countries, including USA, where it will be tested on patients suffering hospital-acquired pneumonia. And in that, under a very careful supervision, we will be testing this. And probably, if all goes well, then it will be starting to be given to patients after that. But there will be a phase 3, but depending on compassionate ground, once you have cleared a phase 2, that means you have shown, the phase 1 shows that your molecule is safe, and phase 2 shows it is efficacious. Now, in the antibacterial field, efficacy is already, we have shown in animals, in multiple animal species. So in the phase 1 is the major criteria where we have to see that it is safe. When you give the right dosage is there in the blood. We measure the amount, whether you give it oral or IV, at various time intervals, you measure the concentration of the molecule in the blood and see whether it is there. And once you know that it is there, then you know that if it is the right amount of concentration, which is enough to kill the bacteria, then the efficacy will be there. There is no doubt about that. So the phase 1 is the most important, but phase 2 we have to do. And then probably by the end of next year, hopefully the phase 2 will be over. And then we can think of clinic.
Very good. Well, Dr. Datta, what's the best way for people to keep tabs on your work and to find out more?
What's the best way? The best way. Website is updated. You can just drop in a line to me. I would be more than happy to update maybe 3 months from now. I think the next gating is once the FDA says okay, then the clinical trial. But I hope that the COVID-19 it will derail time by maybe a couple of months, but not more than that. So that's what we are hoping.
Okay. Well, very good. Well, thank you for coming on the podcast. I appreciate it very much.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.